Hi, everyone. I'm Dr. Faisel Sayed,
And I'm Dr. Dan McCarter.
and you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Today, Faisal and I are talking about managed care, then versus now. Let's dive right in.
Hey, Dr. Dan.
Hey, Faisal, how are you?
I'm doing really well. It's been a while since it's just been you and I just kind of talking shop.
I know, and we've been out and been meeting a lot of people, so it's probably a good time to come back and have another conversation.
I know. There's so many different things that we've heard. Just from doctors who are, they feel alone, they feel disconnected, and then you've got that, and then on the other side, there's a lot of misperceptions about the full risk model, value based care, the work that we're doing at ChenMed being compared to like, oh well, that's what was being done like the managed care in the 90s, or value based care and value based payment are being used interchangeably. People who are taking mostly fee for service are getting lumped in with us who are full risk. We don't do any billing. So in the 90s, when all this managed care, all the even the talk of man, you lived through that.
Right.
What was, let's explain it to someone who doesn't know. Let's try to I would love to use this conversation as an opportunity for somebody who's like, hey, really, what's going on now that's so different than before? This has to be the same of what they had before.
Yeah, well, and John Cotter, who has written the book Leading Change, has also written a book about buy-in and getting people to when you're working through issues. And one of the phrases that he would like to use is that was then, this is now. So that's the one thing I would say is, yeah, it didn't work in the early 1990s, but that was then, this is now. And then you most medical records, especially ambulatory records, then were still handwritten.
That's
I
right.
mean, I was on a computerized medical record, but that I was the exception, not the rule then. And there wasn't any good data reporting coming out of even the inpatient EMRs. You were getting a little bit of information on some of the preventive measures. And the main thing you were getting information on was how many tests you were ordering, how many expensive tests you were ordering, how many referrals, how many emergency room visits, but it wasn't tied to the patient's risk at all. And there wasn't any risk adjustment going on for the panels. I mean, so there was a lot of cherry picking, people trying to get rid of their sick patients and give them to somebody else and get healthy patients. There were people who were building their offices on the second floor of buildings without an elevator so that people had to walk up the steps to get to them. So they had to do a stress test before they could even get in the office. So
Oh
that,
my gosh.
those are a few of the things that are different.
Well, clearly that is not happening now. At least to that degree. It may be happening like a little bit more in a little bit more sophisticated manner. Um, the difference though with risk adjustment, like if you're taking on responsibility for health outcomes, right? To avoid the system, even the people with the best of intentions. The human nature is to like we want to go to low risk. We don't want to put ourselves in dangerous situations. So I'd like for you to talk a little bit about the benefits of risk adjustment to someone who may not understand what that means. I mean, how do you bypass the whole cherry picking process? Like, hey, I'll take full responsibility, or I'll take more responsibility for health outcomes as long as I can pick healthier patients versus just looking after a community, for example.
Right. Well, I think it gives you a balancing effect, right? So if you have say I've got a practice full of patients that are 72 years old with 3 or 4 or 5 chronic medical conditions, and I've got a fairly small panel, but I see them fairly fairly frequently and able to keep them healthy and out of the hospital, if you're taking the full financial risk, then you've got to have that additional money to see them, to justify seeing them frequently, so that there are the revenues there, top line, to work on that. Um, the as far as, and if you have healthier patients, then you might not need to see them as frequently, but it really does help balance things out, right? And
Yeah.
then it creates models to manage the panels. And so what it does do is it creates models like ChinMed for one, but there are other people who work in this complex chronic care who focus on that and provide more resources, larger teams, more robust surrounding for the patient who are sicker, but you've got to have more revenue to do that. Whereas somebody who is wanting to take care of a younger patient population would probably allow more virtual care, uh, less concern about the patient seeing their individual practitioner, but just having that access, not having to go to the emergency room. It's just, I think it helps you focus on what the needs of the patient have, the patients that you're caring for, the population that you're caring for, don't you?
Yeah. Well, I mean, I think we're just so a lot of it is that we're still feeling the negative impacts from the '90s. Is that what you think is going on? I mean, if they weren't fully responsible, if they weren't taking the full risk, right? Let's say if they even had patients who had medical concerns, if they're not taking downside risk, then why? I mean, I'm not surprised that necessary referrals weren't being made, the proper medicines weren't being prescribed.
Right. And I think people who got risk, I mean, risk means more things can happen than will happen. I
Yeah,
mean, I'm taking that from a book Howard Marks wrote about investing. But but the issue is you also have to have the data to be able to manage the risk, right? I mean, so you wind up having the panel, and we could talk about where the 2500 panel came from, which apparently sort of appeared in an article in 2000 out of thin air, and now people have just bought into, well, a doctor's supposed to be able to care for 2500 patients. But if you have hidden in that panel of 2500 or 2000 or 1500, 6, 8, or 10 really sick patients that are driving the cost of the panel, but you don't have a way to identify those before they actually hit the hospital in the emergency room, that makes it very difficult to do as well. But I mean, the IT systems are so much better now. I mean, in the early 1990s, when all this started, there wasn't an internet, right?
that's right.
Well, I guess there was, but it was academics and defense were
Sure.
using it. But there wasn't a world wide web the way we use it today. There weren't, everybody wasn't walking around with a computer tied to their belt, that also functioned as a phone and a music player and all of that. So I think there's just so much more rich data available now. But it takes people who know what they're doing to analyze that data.
Yeah, we need the data. The data has to be there. The ability to be able to interpret the data, that's got to be part of that. That's got to be part of the culture. We had Gordon Chen on recently, and he really started teasing out these different models because everybody's kind of getting lumped into like the same mix. We obviously we've got on one extreme, we've got the sick care system, the transactional billing sick care chief complaint system. And then the first baby step out of that are all these different value based payments within like the value based care system that's still really heavily rooted within the fee for service model. But comparing that to the full risk model, to me, it's like worlds apart still too. I mean, that to me feels a lot more like what was going on in the '90s than a lot of the transformative and even the outcomes based stuff that's happening now.